Okay, good evening, everybody. This is Dr. Brett Haake. I'm here live with my wife, Dr. Felice Haake. We are excited to be here. We're doing the Preventus Podcast live from Ikaria Concierge Functional Medicine, and we're excited to be here. We kind of called a very quick podcast tonight because we wanted to talk about some recent developments that have happened in the world of medicine that we're actually really excited about. And that really has to do with the announcement that our FDA director, Marty McCary, made about removing the black box warning for estrogen and the overall approach and guidance that the government is now providing with regard to hormone replacement therapy in women. And so we're excited. We want to talk about that. We want to hit on a lot of those topics, but we really want to kind of connect with the audience. And I think to really start off, I'd like to kind of introduce my wife, Dr. Felice Haake.
Hello.
And we, like I said, we are the owners and the operators of Ikaria Concierge Functional Medicine. And so I think what I think is interesting to the audience, and I think what's interesting to potential listeners and even patients, is how did a primary care doctor, a family practice doctor, and an anesthesiologist, that's me, how did we get involved in the kind of medicine that we're practicing? And so the first question that I want to ask my lovely wife is what's your background and how did you get to this point?
I thought you were going to say, how did we get together in general?
Oh, well, we could talk about that. That'd be really interesting.
That'd be a whole other podcast.
That'd be a great podcast.
We're not going to do that today.
That'd be a great
promise.
podcast.
We won't. It'd be a snooze fest. No. How did I get into functional medicine? Was that your question?
Yeah, how did we get to the point where we're at today?
Yeah. So, all the way back before I decided I wanted to become a doctor, really. I was going to University of Florida. I was never really an A student, and then kind of got bit by the bug. I just had this moment where I was like, I think I want to get straight A's. That's really what happened. I was a psych major, and we've told this story before, but I'll laser it. I essentially started taking classes in psychology and then ended up in this physiologic psychiatry class, and it just blew my mind how much I loved science. I don't think I ever really gave myself a chance at science, and that was the end of it. So I started down kind of a nursing path, and then through a whole bunch of convoluted routes, ended up in medicine, and went to NYU because I didn't graduate UF with my pre-med. So I had to go back to NYU for a post-baccalaureate pre-medical program. And there I took all the classes that are, criteria, your organic 1, 2, chem 1, 2, bio 1, 2, awful classes. So all those out there who are going through that right now and you're thinking to yourself, do I really want to be a doctor? I promise you those classes are just a means to an end. But anyways, ended up at Nova Southeastern where I met you, and was just going to be in conventional medicine. And honestly, the first person who introduced this type of medicine to us was your dad, and we thought he was a nut.
I remember that very distinctly. This is well over 20 years ago, and he was telling us he was getting people off of his medications. And of course, at the time, we're young medical students, and we're like, that's absolutely crazy. People
That's impossible.
Can't come off their medications.
Yeah.
And so that was, little did we know that we would, at one point in time, in some point in the future, follow in his footsteps. But right, I mean, so we did residency. I was military, of course. You were civilian.
Yep.
And then, we lived in Virginia for a time, eventually moved to Florida.
Had a couple kids.
Had a couple, 3 kids. Yep. That happens when it's crazy what happens when you start studying together. It's really interesting what happens 20 years down the line. But what led you to get involved in the kind of medicine that we're practicing right now?
So I go through family practice. So, we go to medical school, and in medical school, you make your decisions on what area of medicine you're going to go into. And, unfortunately, we've really divided ourselves from each other. You have cardiologists and urologists. And so I really just kind of didn't like a lot of things, to be honest. I was like, I definitely don't want to do surgery. I definitely don't want to OB-GYN. And I really just thought, you know what? Family practice is the one I disliked the least. I honest to God chose it based on that. And then through family practice, I started to really like helping people lose weight. And I was in family practice residency, and it was to the point that, the nurses would knock on the door like, you're falling behind, because that was the time I really wanted to spend with patients, and was when I was helping them lose weight. And so I kind of started to look into a type of medicine called bariatric medicine, linked up with a surgeon up in Virginia who's a bariatric surgeon, and actually went and got my board certification in that, in what they call obesity medicine or bariatric medicine, which is helping people lose weight. But what I really, really liked about it, and this is where it kind of turns, and I guess the tides turned for me, was these people weren't just losing weight. They were coming off their diabetic meds. They were not needing the same blood pressure meds. They were feeling good. Their cognitive function improved. I mean, every aspect of their life improved. And so I was like, wait a second, there's something more to this. This isn't just weight loss. And then honestly, through your dad, being a nephrologist and falling into A4M, which is, the Anti-Aging Society, we started going to those conferences, and I really started to like that. And it just trickled into this. And I guess in 2018, was it 2018? I started doing this full time.
2018, and at the time, I was working as a full-time anesthesiologist. I still do a lot of work in the OR, and we had a stem cell clinic in the community, and I realized very quickly, right, that a lot of our patients that were obese, had inflammation, had insulin resistance, weren't getting any better. And
right.
So I understood let's say I was semi-fluent in the kind of medicine that you practiced, but I knew that if we could start getting these patients to start losing weight and become less inflamed, that eventually, the stem cell would be more effective,
right,
and work more effectively.
Right.
So that was the start of it, and that was in 2018. And it turns out and here's the cool thing is we don't always agree on things, right? We have we argued probably for about a year about whether or not you should leave the hospital.
I know.
And I begged you for about a year, and then eventually you came on board, and within a couple months your practice really started to explode.
We have different approaches. You're the cannonball into the water, I'm the toe.
Well, and I think you need a little bit of both, right? For
Yeah.
life, you need a little bit of both. There's a little bit of mixture, but the bottom line is that your practice started to explode, so much so that, eventually you decided to go concierge, and also you got really involved in the entire aspect of not just bariatric medicine, but all of functional medicine. And that includes trying to understand prevention, trying to understand cardiovascular risk, really doing a lot with the A4M and really hormone replacement therapy, understanding what that means, how to implement it, and really improving your offerings to patients so that not only can you prevent disease, but you look at a patient and say, hey, I want to make you more functional right now. And I think that was sort of the appeal. And that was kind of, sort of right off the bat, 2018, 2019. And so talk to me a little bit about how that practice evolved and then how we got to where we're at right now with Ikaria.
Yeah, so Ikaria is 6 months old, and it's been obviously like a little glimmer in our eye for a long time. I think we always knew we wanted to go out on our own and do our own thing, considering we started this really all in 2018. And the evolution, I mean, the type of medicine is twofold. You have functional medicine, which you just described eloquently, and then you also have concierge, which, the concierge approach sort of fell into my lap. I had patients who were asking me, would you be my concierge doctor? That's how it actually started. And so I started to get this following, small, like trickling in of concierge patients. And what they were looking for was actually exactly what I was looking for, and probably most doctors are looking for. I wanted to spend valued time with patients. I wanted to help them through, whatever ailments they were going through. I didn't want to be compressed in terms of time by insurance companies dictating you can do this, you can't do that. I wanted to essentially eliminate the middleman. most patients will say, man, do you really like being on 24/7? It's fine, because the reality is concierge medicine, you take care of a few people well. You can't have a panel of 3,000 to 4,000 patients like your average regular, primary care doctor has. So that's where it's a kind of a two-prong approach. You have the functional medicine approach and the concierge approach. And I think it marries very well. So patients who are looking for what we do are really looking for deeper dives. They're really looking for understanding of what their, true health is looking like inside. I think most would agree that their primary care doctors, and no offense to them, I was a conventional doctor too at one point, they don't have enough time to really dive deep. That's the problem. So that's how I kind of fell into this.
We could do a whole other podcast on the economics of medicine, the economics of time, and where we're at in our conventional state. But I think you made a great point, is that we're really doing, if you get down to the nitty gritty, we're really doing two things. One is we're doing the functional preventative approach, and that's a whole thing that we're going to talk about, but also it's the direct access primary care. So anytime you need anything, whether it be you need an antibiotic called in, or you need to be seen because you've got a migraine headache, or you've got a question about, whether or not you should get a CT calcium score, or you want to discuss the benefits to risks of hormone replacement therapy, you can have an immediate conversation and immediate access to your doctor. So it's kind of nice with our practice, because you get some folks that are like, I just read my 12th functional medicine book, and I want all things functional medicine, and I want my VO2 max, and I want to do photobiomodulation therapy, et cetera, and I want all these peptides. And then you have folks that have never actually heard of functional medicine, and so we have something for everyone. And so with I'd say most people are probably on the spectrum where maybe they know a little bit about functional medicine, but a lot of times they just need a good doctor to kind of take care of them.
Yeah, and I think also, can I just jump in here?
Yeah.
I think some patients will actually think, well, they do functional medicine, so they don't do regular medicine. It's like, no, actually, if you have a urinary tract infection, I'm going to treat it with an antibiotic, because that's what is best for that condition. So I find that a lot. They kind of don't think we do actual conventional medicine as well. And of course we do, when it's warranted. So it's really just a deeper approach, I'd say.
And I think you bring up a great point, because on our next episode, Dr. Grace Fromang, who's joined our practice, is going to come on board with us. But between the three of us, we have board certifications in emergency medicine, osteopathic principles and practices, family practice, medical bariatrics, anesthesiology, transesophageal echocardiography, the American Association of Anti-Aging Medicine, and lipidology. So there's a lot of expertise brought to the table within the conventional realm. Mm-hmm. And then you throw in the component of the prevention and the functionality, and this idea that we're going to sit down with the patient. And, one of the things that we ask our patients is, what is it that you like to do? Okay, let's say you're 50 years old. What is it that you like to do? What is it that makes you you? And they might say, hey, I like to surf, or I like to fish, or I like to garden, or I like to work out. Whatever that is, we want you to be able to do that at a high level all the way until the good Lord calls you home. We don't dictate that day. Obviously, if we're doing our job, we can increase the chances of that being longer away than shorter away. But also, what a lot of people don't talk about is those years of life that you're highly, highly functional. Of course, we call that health span. But if we're doing our job, you should have a very, very good health span, or at least be functional all the way until that day that the good Lord calls you home. And that is our sole passion. That is our sole objective. And that's really what we're trying to do here at Ikaria. And I think that leads into another, kind of question, is what is an anesthesiologist?
Yeah.
What is an anesthesiologist doing in the realm of functional medicine and even clinical medicine? And I think that's a really good and fair question. And you and I, here I am, the one that asked you to come into our clinic and work as the primary care doctor, as the functional medicine doctor for our stem cell clinic, thinking, hey, I'm a OR doctor and I'm never going to get involved in this kind of medicine. And it's a great story, but a little over 2 years ago, I was playing basketball at the age of 45 with a group of friends, and I, thinking that I'm still 21, was in the middle of a game thinking I'm playing really good, and I tore my patella tendon in half. And for me, it was one of those things where I really didn't understand the severity of the injury. I didn't understand how physical my job was as an anesthesiologist until I actually had that injury. And so for the next 2 weeks, I really didn't do this, but for the next 2 weeks, I was told I can't do anything and I have to just basically sit around the house, which for me is torture. And so the only thing I could really do was read. So you have all of these books laying around the house. You've got Avalon Blooming, Estrogen Matters, Near Barzilay, Age Later,
Nature Wants Us to Be Fat.
Rick Johnson, Nature Wants Us to Be Fat, Peter Attia, Outlive, Abraham Morgan Taylor, Testosterone for Life. And I started picking up, I forget which one I started first, but I started reading, and I literally couldn't put the book down. And all of a sudden I started thinking to myself, the light bulb went off. And so for my entire career as a cardiac anesthesiologist, I've spent my time taking sick vascular patients to the OR, and my colleagues and I, both surgical and anesthesia, sit down and we all say, none of us want to be that patient. None of us want to be the patient getting our neck cut on, getting our chest cut on, getting our abdomen cut on, and having our vessels fixed, if you will. None of us want to be that patient going for grafts and all these kinds of things. And so I started thinking to myself, why aren't we sitting patients down and teaching them, giving them the tools so that they can avoid or prevent being in this predicament in the first place? So that sent me on a quest to try to really understand disease and pathophysiology, which is disease pathology, and really how it develops and what we can do to avoid and prevent those things from developing. And so,
because you had a really unique view that other people don't get, I didn't even have, of end stage.
And like I think it's one of those things where if there are any anesthesiologists out here listening, I do think we do bring some gravitas to the table. Because, for instance, if I have a 50-year-old that we're taking for a heart surgery for what's called a coronary artery bypass graft, I can see very clearly how the medicine that we use to put them to sleep affects their blood pressure very differently than someone the same age who doesn't have coronary artery disease. And so I can actually see very clearly how that guy might be predisposed to just sudden death if he's out cutting his grass and he gets dehydrated, for instance. And so it really was eye-opening, and it just sent me on this quest to really understand the things that I think we're going to talk about, how testosterone affects the body, what is insulin resistance, and how do we understand insulin resistance and metabolic health so that we can teach our patients really how to avoid it.
And each one of those things could be an entire full podcast.
Whole podcast.
Yeah.
What is plaque? What is vascular plaque? Why do we develop vascular plaque? What do we have to do to not have plaque? Is plaque in your coronaries, is the development of plaque in your heart vessels different than the development of plaque in your brain vessels? Is that different than the development of plaque in your other blood vessels throughout the body? So these are things that I started to question. And then I kind of, you and I have both discovered that really in the United States, there are not really good incentives in the conventional realm to actually sit down for a whole number of different reasons. And there's no doctors and healthcare providers in general are the hardest working people I know. This is not a throwing stones endeavor. This is, hey, what can we do to actually get the people to think differently? What can we do to actually, get physicians to think about things differently? And so I think that one of our passions is really, just getting thinking about sitting patients down and preventing. So talk to me about this. Why are we here? Why does Ikaria exist? What is our goal, and what are we, if someone comes here, what are we offering? What is the benefit of coming to
I
our
think
clinic?
first and foremost, we're offering time. I think and access. And I think most people who are in the conventional sphere in terms of dealing with primary care doctors know. I've had patients tell me they have a urinary tract infection, they need an appointment, and they can't get in for 2 weeks. That's real, okay? And then Dr. Graves would probably agree. He's got people walking into an emergency room for UTIs, which is also ridiculous. So it's access and time. That's number one. Number two is really taking a deep dive, really understanding what you're dealing with. I've had patients come in with, I'm tired, I'm cold, I'm depressed, I'm gaining weight. And it's like, well, here's an appetite suppressant. Here's an antidepressant. Here's a, some sort of pill to handle each symptom, instead of the reality is this is a person walking around with low thyroid. That's suboptimal. So that's what we're doing. We're really trying to get to the root cause and understand what's happening with patients, giving them the time, giving them the access, and then prevention. Really, we're very focused on prevention. We do not claim that we're going to make you live forever. That's impossible. But we do believe that you can slow the aging process, and there's tremendous amount of studies out there that also believe that and can testify to that. And then in addition, we can not just slow the process, that we can keep you more functional for a longer amount of time. So that's what anti-aging medicine is. I think some of our colleagues might laugh at it as if to say, we think you can live to, the ripe age of 120. No, we don't. Okay. But we believe that you can have a more functional life later in life, in the last decade.
You bring up a great point, because you will hear people from time to time make comments to the effect like, oh, I like vitamins too, or, oh, that's Eastern, or it's homeopathic, or, whatever term they can use to basically demonstrate that they don't really understand what we're doing. And so when we say prevention, okay, one of the things that's sort of our hallmark, I think if you could define our strategy in one term, is we're measuring the amount of metabolic dysfunction that you have, or what we would call insulin resistance. And the way that we understand insulin resistance is, from a cellular level, it's just the cell's inappropriate response to insulin signaling. And from a global level within the body, it is not just what leads to type 2 diabetes, but it's actually upstream from probably about 95% of all non-communicable diseases in the United States. So this includes not just type 2 diabetes, but it includes fatty liver, it includes Alzheimer's disease, it includes multi-infarct dementia, it includes coronary heart disease. Over 50% of everybody that gets diagnosed with type 2 diabetes already has coronary heart disease. It includes peripheral vascular disease. It includes erectile dysfunction. It includes polycystic ovarian syndrome. And so the really what we're trying to do is measure the amount of metabolic dysfunction that you have, and then attempt to reverse that with a whole series of different things. So that leads into the next thing that I'm actually really excited about. I know you're excited about it as well. And Marty McCary made an announcement last night, and then of course RFK brought a lot of his physicians on to talk about it today, and that is the government is now removing its black box warning on estrogen. But not only that, I think Marty McCary made some phenomenal statements last night, specific to really a guy I think that deserves a lot of credit, who I think has been taking a lot of incoming, and I think unnecessarily, for the last at least decade. And that guy's Avron Blooming. Mm-hmm. He wrote a book called Estrogen Matters. And so talk to us a little bit. You have more experience dealing with the perimenopausal women, but talk to the audience about what McCary's statement was all about, and really what hormone replacement therapy can do for the patient.
Okay, well, with respect to time, McCary came out and basically said, we're going to remove this black box warning, which is this warning on, hormone replacement therapy has been going on for a very long time, decades. And in the late, I guess it was late 90s, early 2000s, there was a very large study, Women's Health Initiative. Again, an entire podcast could be done on this, that really kind of put out this statement that hormones were bad. And so this kind of genie that got out of the bottle from this study, which, has now been reviewed and retrospective studies have looked back at it. Even the original researchers of the study have come forward and said, okay, we were wrong. But again, this is lasering, this study, which in any event created this kind of mass chaos.
The bottom line, just to summarize,
bad hormones,
is
right?
The study, the release of the study is what we call a type 1 statistical error. They claimed to find statistical significance in a study that did not find statistical significance.
Exactly.
Specifically, what they talked about is in the progesterone estrogen arm of the study in women that had uteruses against placebo. So there was one group that got placebo, the other group got progesterone and estrogen. They claimed there was a 26% increase in the incidence of breast cancer in the progesterone estrogen arm, but that increase was statistically insignificant, and it amounted to an increase of 8 out of 10,000 in increased incidence of breast cancer. But out of those 8, there was no increase in mortality. Of course, the average age of the woman in the study was 65. Many of the women were obese. Many of the women had insulin resistance. Many were smokers. And the curious part of the entire study is in the group that did not have uteruses, the group that was getting estrogen only against placebo, there was actually a reduction in breast cancer in the estrogen only group. So how can you say in the same study that estrogen is causing breast cancer when in an entire other group of the study, estrogen actually lowered the incidence of breast cancer?
And that part was completely clouded over.
Ignored. And so the reality is, and this is what I love about Ikaria coming out last night, the reality is that what are the benefits of hormone replacement therapy in women?
So their indication is for vasomotor symptoms, okay? So hot flashes. So if you look at the indications, that's what the FDA is indicated for. But there's far-reaching benefits. Reduced risk of cardiovascular disease, reduced risk of strokes, reduced risk of osteoporosis and fractures from osteoporosis, which, what's the statistic on mortality after a hip fracture over the age of 70? It's 20% mortality.
And I think it's one of those
within
things.
1 year.
I invite anybody that thinks that osteoporosis is not an important thing clinically to just come with me to any OR on a Saturday in the state of Florida, and I'll show you a successful hip fracture.
Right.
The reality is, even in patients that are healthy, even in patients that don't have a ton of comorbidities, specifically women and men who fracture their hip, their loss of functionality, they'll never regain the level of functionality that they had prior to the hip fracture. So the best way to treat a hip fracture is to essentially prevent osteoporosis. And one of the best ways that you can prevent, if not the best way to prevent osteoporosis, is through hormone replacement therapy. And you mentioned the other thing. You mentioned coronary heart disease. The reason premenopausal, one of the reasons premenopausal women by and large do not get coronary heart disease is because they have estrogen. One of the things that I'm not sure if you mentioned or not is women get Alzheimer's twice as often as men. The best way to, Alzheimer's is incurable. There's no cure for Alzheimer's. The best way to treat Alzheimer's is to prevent Alzheimer's. And one of the things that helps with cognitive, to prevent cognitive deficits and neurologic decline is bioidentical hormone replacement therapy. Yeah. So
reduced risk of metabolic disease as well.
Correct. I'd say the big four are reduced risk of osteoporosis, reduced risk of coronary heart disease, reduced risk of dementia and Alzheimer's disease. And then it's a tool in the armamentarium that we have to make the patient more metabolically healthy or reverse their insulin resistance. One of the reasons women gain weight as they hit menopause is they become hormonally deficient. So when you replace those hormones in a natural way, it's one of the tools in the armamentarium. Of course, you and I would also say that a scientific and medical approach to diet, exercise, and sleep and stress is the foundation, and all the other things are really icing on the cake. But hormone replacement therapy is a very, very valuable tool in that armamentarium. So,
and now with this statement that came out, I mean, I'm just hoping it changes, not just my patients' views. Most of our patients are very pro hormones. They come to us seeking, but I'm just talking patients who are told by our colleagues that hormones are bad. I'm really hoping this makes a change, that there's a tide change after this.
I so agree, and I think that not only do I agree with that, but I also hope that we have a more robust discussion on testosterone replacement therapy in the population. And I think somebody that deserves a lot of credit for really doing a lot of work in that regard is Abraham Morgan Taylor out of Harvard. Another guy that I think has done a lot of work in that realm is Mohit Kara out of Baylor. But really, I think the key piece is that when you maintain hormonal optimization as you age, that's one of the key pieces in maintaining metabolic health. So again, in men, a lot of your good studies with testosterone replacement therapy deals in the realm of type 2 diabetes and metabolic syndrome, and you'll see a lot of studies where it helps with improved glucose control, improved A1C, which is how we measure prediabetes or type 2 diabetes, and even reductions in fasting insulin and improvements in insulin sensitivity in the fat cells, the adipocytes that surround your visceral organs. So I think that what is exciting for me is I think we're coming into an age in the United States where maybe we start to rethink some of these things that we've thought about before. And we really, I think, ultimately need to start questioning why it is we're last in all industrialized nations in life expectancy at birth, in spite of the fact that we spend more money per capita in healthcare. And I think once we start doing that, hopefully we have a reevaluation of the way that we think about things. And I think that from a medical approach, we start thinking about prevention and functionality. So
yeah, and then I think really for the purpose of this podcast, if ever anybody wants to, most podcasts have a theme of some sort. We're really kind of just introducing you to different themes or areas that we're going to really kind of take deeper dives on, because each one of these things warrants a full podcast. It's not a brief, quick discussion and moving on. So, just from the standpoint from the audience, what's the purpose? The purpose is to introduce you to what we're going to discuss further.
Absolutely. So what do we do how do we approach maybe a postmenopausal female or maybe a 55-year-old male that says, hey, I've got a family history of heart disease? What are the things that we think about as far as cardiovascular risk and really preventing the buildup of that plaque, and not just their heart vessels, what we call the coronary arteries, but the rest of their body? How do we approach those
We think in terms of metabolic, issues or dysfunction, like insulin resistance as a big factor and big driver of cardiovascular disease. Family history, we think of genetics. There are a multitude of genes that are linked. And we do testing on that. We think of things like MTFHR gene as well, which we test almost pretty much all our patients on first time we meet them to see if they're positive for that gene. So those are some of the things we would think of. Obviously, your lifestyle risks, what you're eating. Are you smoking? Are you drinking a lot? Those are obviously, that's low-hanging fruit. We have to go for that from the get-go with all of our patients.
Yeah, and I think you and I both like to do a lot of teaching when it comes to sitting down with patients. And I think that if you think about the development of plaque, that occurs in an area called the vascular intima, right? So you have endothelial cells that line the blood vessels, and then in between the endothelial cells and then what are called smooth muscle cells, there's something called the vascular intima. And so what happens is the LDL cholesterol particle moves into the intima and it becomes oxidized, it rusts, right? And then eventually that sets off an inflammatory reaction that then leads to vascular immune dysfunction. So that's maybe a lot of Chinese, but I think if we think of it in terms of, there's several really big risk factors. Number one is ApoB. And when we say ApoB in the United States, a lot of times we measure that by looking at what we call the, quote, bad cholesterol, the LDL cholesterol. Typically comprises about 95% of all of your ApoB particles. But ApoB, there's actually 4 different ApoB particles, and all of them can potentially move into the vascular intima and become oxidized. And then we think about controlling your blood pressure. We think about not smoking, so smoking cessation. Oh, yeah. And then we think about metabolic health, so maintaining metabolic health, so minimizing insulin resistance, making the body as insulin sensitive as possible. And those are the big things. And if we can really focus on those 4 big things, I think the chances of you developing plaque are going to be significantly reduced. I do think that the nice thing about what we're doing is that there are also other risk factors. There are things like familial hypercholesterolemia. There are things like what you just mentioned, MTHFR, which is essentially a function of how well you methylate your B vitamins, which we measure that as well. And then the next thing I think, and the thing that we can probably devote an entire podcast to, is what we're doing with Vibrant Labs out of Silicon Valley. And for those of you that don't know, we're fully integrated with Vibrant Labs. They were started by a couple biomedical engineers from India, and they are the most comprehensive functional medicine lab in the world. And their cardiac zoomer, they call it a cardio zoomer, so you zoom in on all the cardio risk factors, is incredible because not only does it measure ApoB, it measures something called Lp(a), which we'll devote an entire podcast to those things, but you also look at things like highly sensitive CRP, you look at things like oxidized LDL, a lot of these different risk factors. But the other thing that I think is really kind of nifty about the way that they analyze things is they will actually look at things like desmosterol, cholestanol, sitosterol. So if you have an elevated ApoB or an elevated LDL, we can actually isolate where that's coming from. Do you have a problem with your enterocyte, which is those are the cells that line your gastrointestinal tract, or is it an issue within your liver? Is it the hepatocyte? So that might mean that you might see an elevated desmosterol. So you can pick the medication. Guide the therapy with regard to where the abnormal ApoB production is coming from. And then the other really cool thing about what they're offering is you can get into like different types of ceramides. So we know that the even numbered C16, C18 ceramides that come from some of your saturated fats can really disrupt insulin signaling, whereas some of your more odd numbered saturated fats, and then certainly your omega-3 fatty acids, so your polyunsaturated fats, and then some of your monounsaturated fats actually enhance insulin signaling. They actually make you more metabolically functional, more metabolically optimal. So it really provides a extremely nuanced, in-depth view of your cardiometabolic risk, and then allows you to make very, very specific and precise, actionable interventions to prevent disease.
And for anybody in the audience who's like, was I supposed to understand anything he just said? No. And to be honest, most of our colleagues and even ourselves, we had to learn this. This is not mainstay of, our education. We actually really have to learn Vibrant. Like I actually this weekend sat and studied Vibrant Wellness Labs, like with pen and paper, watching videos and learning it. But it again, to just echo what you're saying, give the patient a nuanced understanding of what's going on with their health. That unfortunately, and I love Quest, and we use them for most of our just general labs, but they cannot touch on this level of understanding. So if people need deeper dives, they're going to go for something like what Vibrant can offer.
It's exciting, and I think that this is really next generation medicine. I think that the Vibrant piece, it's not just cardiovascular. It gives us, we can look at gut, we can look at brain. I mean, one of the things that we're already looking at is checking the ApoE status of the patient. We look at different types of tau protein measurements. We look at amyloid beta, plaque measurements, and so the neurozoomer can get that. One of the things that I'm really excited about is what's called the oxidative stress panel, and we can look at that as well. And what that does is there are a lot of different markers of oxidative stress and really mitochondrial health. So what it's going to allow us to do is look at some of these problems that we have with patients, guide us in some certain different interventions, and then evaluate the intervention at the end of the intervention. So that leads us into our next topic.
Yeah.
We're excited. The upstairs of our clinic we call the Longevity Center, and Dr. Grace Fromang, who's our newest addition to the clinic, is going to join us on the next episode. So we're going to talk about our offerings with the Longevity Center, what we're attempting to do, and how our patients can benefit. So that'll be our next episode. But we're excited. Thank you, everybody, for listening.
Thank you.
We are Ikaria Concierge Functional Medicine. This is the Preventus Podcast, and we will see you next time.